My name is Jane Jerzak. I am a partner with Wipfli Healthcare Consultants and CPAs. I have been with Wipfli for over 25 years, providing financial, strategic, and reimbursement-related consulting to hospitals and health systems throughout the country. The discussion today is on service line planning concepts for critical access hospitals. The objective of the discussion is to gain a high-level understanding of service line planning for critical access hospitals. The discussion agenda will include the definition of service line planning, the objectives and benefits of service line planning in critical access hospitals, how to effectively use your internal and external data to understand your financial and market position, and lastly, I will be sharing with you a sample of critical access service line planning in a model that we developed. The definition of service line planning. Service line planning is a method of managing patient care around a specific disease track such as cancer or heart disease. Patients with a specific disease or condition typically require a common set of services and may have common needs and challenges. Organizing care around these common needs enables health systems to focus on relevant services and optimize service processes and patient outcomes. In order to effectively create a service line system of management within your health system, the following structure is required. Number 1, defining the key service lines within your organization. Number 2, defining the service line leader and team. Next, you need to understand the cost to deliver defined services, as well as understand the reimbursement structure for such services and payer mix. You will also be identifying the variation in care processes and creating best care practice standards around each service line. And finally, you will need to develop a reporting tool to monitor service line performance. Critical access hospitals are typically considered small health systems that need to manage resources effectively to best meet the health needs of their primary service areas. Many health systems include hospitals, physician clinics, home health departments, and other ancillary services that should be managed along lines of care based on disease state or medical need. Once information is organized and reported along key service lines, critical access hospitals can work to improve the quality and profitability of key services by focusing on evaluating payer performance and working on revenue cycle issues to optimize or maximize payments, understand the true cost of care in providing care for patients within each service line, identifying variation in care patterns across patients or physicians within each service line. It is also a mechanism for maintaining strong lines of communication within various players, particularly physicians, performing within each service line. You will also be able to better predict, track, and respond to changes in mix or volumes using a service line methodology of reporting. It will also allow you to plan for services and scarce resources in the future when you understand your service lines as well as trends in service line performance. Step 1. Using internal and external data to understand your financial and market position. The first step in service line planning for critical access hospitals is to define the key service lines within your organization. Service lines are typically organized around a common disease state or condition, which will require the mapping of services provided, typically via claims, into each category. While many health systems create their own service line definitions based on how they wish to track information, we often see services mapped into service lines as follows. On the inpatient side, we often see services mapped by major diagnostic category, by DRG, or possibly by primary diagnosis. On the outpatient side, which includes ambulatory clinics and ancillary services, service lines are mapped by primary diagnosis and often by CPT code. Based on the definitions and mapping of claims, we often see health systems create the following service line for reporting and management purposes: cancer, ENT, cardiovascular, gastrointestinal services, general medicine services, which may include general surgery, neurology, orthopedics, pulmonology, urology, spine, and women's health. You may determine that some of these services fit within your organizations and others do not. While all health system services should ideally be mapped into a service line, not all service lines will require the same level of leadership and management within the organization. We recommend the top 3 to 4 service lines create the focus for a true service line model of leadership and management, and relate cross-functionally to other service departments within your organization, which may include lab, imaging, therapies, other diagnostic services, routine services, and surgical services, which may include anesthesia as well as recovery. Once service lines are identified, it is essential to understand the current state profitability of the service line for performance monitoring and improvement. To understand current state profitability, we recommend the following analytical process. Step 1, obtain at least 1 year of health system claims for the service line mapping and modeling project. The claims information, supplemented with patient accounts data, will include a wealth of information to help you understand patient demographics, services provided and related charges, diagnosis codes, treating and admitting physician, discharge disposition, payer, and reimbursement, which is derived from patient account records. Next, we will need to identify the fixed and variable cost information by line item and by service included on each claim form, which will be assigned to the claim. Common cost information sources include cost accounting systems in place. If this is not available within your organization, we often use the cost to charge ratios from the most recently filed Medicare cost report to help us understand the fixed and variable costs that are included on each line of the claim. Relative value unit assignments are another method of assigning cost or resource consumption by line item on the claim, or other methods. Finally, pulling it all together. The resource usage measured as a percent of charges, cost, fixed and variable cost, and reimbursement allowed on each claim will allow you to understand the relative significance of each service line, as well as the interrelationships between the service lines and the support services, such as lab and imaging. From this initial quantitative service line analysis, you can begin to understand the cost of care, the variation in care between providers, and can begin to develop improvement goals for the service line. The service line model should be linked to other qualitative and quantitative information to create a comprehensive storyboard for top service lines within the organization, to include things such as physician information, which physicians are supporting the service line, their age, their specialty, as well as physician demand in the market for these services. Quality metrics. How does your system's quality compare to other benchmark standards for the service line? What opportunities are there to improve quality, value, and patient satisfaction by focusing on service line performance? Market metrics. What percent of the market share does your organization have for top service lines? What is your opportunity to expand the service line? Sources to measure market share by service line include state hospital associations, Medicare claim data, or other sources. And financial. How does your service line profitability align with other service lines within your organization? What is the market potential to expand services? And does your organization have sufficient capacity and resources to do so? Next, I'm going to be providing a sample hospital service line modeling. And this is a critical access hospital that used our financial analytics tool to understand their profitability by service line and help them to make key strategic decisions. The chart that is viewed on this sheet includes all of the hospital's charges organized by service line for 1 year's worth of data. As you can see on the left, we have listed the service line. The next column includes the billed charges for that service line, as well as the reimbursement on each claim for the service line, the service line's direct cost. Next is the service line's contribution margin, which is calculated by taking the reimbursement minus the direct cost, as well as the contribution margin percent, which is the contribution margin divided by the reimbursement. Once overhead costs are allocated, we have come up with or derived a total cost for that service line. The reimbursement minus the total cost equals the total margin for that service line. And the percent of total margin is calculated by taking the total margin divided by the reimbursement. If we look at this critical access hospital, we will see total charges of approximately $50 million. We will also see reimbursement of approximately $34 million. Once we subtract the direct cost of providing those services, we can calculate a total contribution margin of $19 million, or 56% of reimbursement. Once the overhead costs are allocated to each service line, we have a total cost of $29 million. The total cost minus the reimbursement of $34 million equates to a total margin for this hospital of $4.8 million, or 14% of reimbursement. You will notice that the top services that are generating the highest volume of charges also generate, for the most part, the highest contribution margin for this hospital. However, once we allocate overhead to these service lines, you will see that the total margin fluctuates somewhat, where some services that have a lower level of charges actually have a higher level of total margin than those that are generating more charges. This is because of the way and the methodology this hospital used to apportion overhead costs to each of its service lines. Next, you are seeing this very same hospital data organized by service line for inpatient services only. If you recall, their total services were over $50 million of charges. Inpatient services only included $14.5 million worth of charges. So you can see the predominance of outpatient services in this hospital. For the $14.5 million worth of inpatient charges, reimbursement was approximately $10 million. Once the direct costs were allocated, their contribution margin was $5.7 million. However, once we allocated the overhead costs related to the inpatient services, such as the overhead related to the facility and the infrastructure to care for patients 24 hours a day, the total cost was $10,500,000, creating a total margin of approximately 1%, far short from the facility as a whole. You will also notice that the service lines comprising the inpatient services for this facility are somewhat different than the total charges of total services presented on the previous page. Inpatient services are dominated by orthopedics, pulmonology, women's health, gastroenterology services, and cardiovascular services. Pulmonology services are predominantly Medicare focused, paying cost and no more, and you'll see the total margin on pulmonary services is a negative 6%. Women's health services are predominantly comprised of Medicaid services, thereby reflecting a negative margin as well. Conversely, you'll see things that are smaller in value for inpatient services by service line, but generate a positive margin for the hospital. This is a function of their cost structure, as well as their service mix and reimbursement on those services. Outpatient services generated by this hospital were over $35 million for the year. After reflecting the direct cost, there was a contribution margin of $13 million or 57%. Once the overhead cost was allocated to these ancillary services of $18 million in total cost, the total margin was over $4.8 million or 21% of reimbursement. You'll see on the outpatient side that GI services dominated their activity, which was made up of colonoscopy and other diagnostic and procedural services. Second was general medicine. Third, orthopedics, cardiovascular, and pulmonology were fourth and fifth in the lineup. You will see on the outpatient basis that once overhead was allocated, almost all of the services generated a positive margin for the facility. Next, we wanted to understand the inpatient days and discharges by service line. And you will see that 84% of the patient days were in the following service lines. Predominantly pulmonology and women's health and newborn were the top services for this hospital. Next, we wanted to understand the hospital's risk for what we would call ambulatory sensitive conditions. This is a slice of days and cases related to the pulmonary service line for inpatient services. You will note the DRGs that we have organized into the pulmonary service line for inpatient cases. They had 176 discharges and 472 days of care. We've identified with the shaded DRGs the types of cases that Medicare may deem to be ambulatory sensitive or with the possibility of being treated on an outpatient rather than an inpatient basis in the future. For this hospital, those ambulatory sensitive conditions calculated to a potential of 39% of days and 41% of discharges for the pulmonary service line. Again, helping them to understand how to strategically plan for a possible drop in admissions in the service line in the future. Next, this chart is representing the charges for the total facility, the reimbursement for the total facility, as well as the cost and margin for the total facility, however, organized not by service line, but by major payer. You will note that Medicare and Medicare replacement plans comprise the largest level of charges for this facility, almost 43% of total charges. After considering reimbursement compared to total cost, you'll see that the total margin for this organization from Medicare was minus 2%, which equates to their cost less the sequestration for that year, or 60% of charges. Commercial insurance, while generating $14 million of charges, generated over $5.9 million in total margin, and this hospital was receiving about 97% of charges on average from their commercial patients. You can see Medicaid charges as well as cost generated a significant loss for the organization, a 33% of reimbursement, and being reimbursed 46% of charges, as they were with one other large payer and another at 54%. Self-pay was essentially getting reimbursed cost, and you can see there was a positive margin on their self-pay patients as well. This chart helps the organization to understand where their cost is situated and how commercial and other payers would reimburse them as a percent of cost, which is also a surrogate to if they are making money or if they are losing money on that particular payer. In summary, service line planning is a formal process of identifying, organizing, reporting, and evaluating key services within your organization for more effective monitoring of performance and more effective planning for the future. It enables you to understand the profitability associated with the service, as well as key drivers to the success of each service line. It also enables you to predict, track, and respond to changes in case mix or volumes, and to plan to expand services and resources